we're just going to take a moment and revisit the concepts of assessment, to just have a discussion and demonstrate what I'm talking about, and also bring in some other concepts that might help illustrate or help one understand what might be going on. Not what's definitely going on, but what might be going on. So when we're talking about assessment, we have the concepts that we've put out there before of macro identifies micro. So big movements are made up of smaller movements and smaller parts. And when you make the big movement, if there's a discrepancy or a problem in the big movement, the small part shows itself, it identifies itself. So big movements identify smaller problems. So the big scale identifies the problems that are in the subcomponents of that. We talked about preferably using patient active or patient active movements for assessment prior to patient passive movements, and we talked about essentially the concept of palpation to help us start to identify this. So get as much as you can touch, move from the known to the unknown. Specificity is not the number one necessity. Things of that nature. We also talked about the fact that within assessment we want a clear-cut algorithm. Okay, so and then when our algorithm doesn't show us the problem, we need to know how to build a new one. So all of those things kind of come together to frame this discussion. What we want to talk about is the concept that with assessment, whatever your algorithm happens to be, do it on purpose. Don't just do it because somebody else told you to do it. Think about what you're doing, think about the algorithm that you're creating, why you're creating it, what it's going to show you, what you're looking for, things like that. So with the algorithm that I've shown before, and that I will also show essentially again in some way, shape, or form, I'll show an algorithm of assessment, big movements to identify smaller problems. What we want to look at is the concept that I am probably including things and purposely excluding things. So we have our algorithm, we have our big movements to check. Now we may not check everything. We may not check every small movement. Some people would disagree with that. They would say that you need to check every joint, every movement to have a complete assessment. What I'm going to suggest is that with those big movements, if nothing crosses a certain threshold of motion dysfunction, that I don't necessarily need to check it farther, unless my large assessment doesn't necessarily show something. Show something in the area of complaint for the patient, or show something of interest for myself as a practitioner. What we want is within those big movements, or what might be ideal is within those big movements, if nothing shows itself as abnormal or a problematic motion or motion dysfunction, then we just move on. We don't necessarily need to check every single small joint. Checking every small joint might be too much information for us to take in as practitioners. Our minds don't necessarily work that way. To attempt to remember the diagnostic naming, right? So whether it's side bending left, side bending right, something's flexed, something's extended, any combination thereof of every joint, we're going to have a big problem. We're not going to remember that. We're not going to recall. We won't necessarily know where to go. So the concept of macro identifies micro, or big movements show small problems, allows us to say, below a certain threshold of motion dysfunction, I'm not going to be particularly concerned, because it's not showing me a problem that would cause other parts of the body to behave differently as far as movement's concerned. So what I want to do is check my big movements. If nothing shows up, I don't go deeper into it. So as an example, if I was using the limbs for very large motions in order to essentially cut the body into four, so right side, left side, same thing with the legs, cut the body kind of down the middle. If there's a problem as I move the right arm, then that's the quadrant I'm going to be interested in. As far as that's concerned, I can go in and I can investigate further within that quadrant to see what may or may not be going on. That may not work for everybody, but what we want to do is use the big movements and only remember the big problems. Right? To try to remember more than 3 big problems or 4 big problems or even 1 big problem in some circumstances might be too much load cognitively within a given search pattern. We just won't remember it, so it may not necessarily become useful to us. So what I'm suggesting is you use that large motion approach, identify a large problem, and essentially minimize your memory of the smaller problems because they are likely not as impactful. It's possible that they are. How would you find out if they're still impactful? You deal with the big problem and the small problem still persists. That would suggest that it needs more attention. So what we want to talk about here also is purposely leaving things out. So in an algorithm that I've shown before, and I'll show again, I purposely, when I'm checking the vertebral column or the torso, I purposely just use the coronal plane. Now, why do I just use the coronal plane? Because if there's a dysfunction, it's more likely unilateral. How did I figure that out? Over time, I purposely, and as I was taught, I went flexion, extension, side bending in both directions, rotation in both directions to identify which plane the problem lived more so in. What I found through doing that time and time again is that there was a lot of redundancy, and it didn't necessarily show me what I was looking for, or show me much of use in a practical sense to work with that patient. So what I ended up doing was purposely choosing one plane of motion, whether it was sagittal, coronal, or transverse, and using that for a little while to identify which one gave me the most bang for my buck. So that essentially is a purposeful process of mixing explicit learning and implicit learning. So explicitly, I tried one at a time, I saw what it did. And implicitly, over time, every time I did that, I learned more and more. So I purposely started to exclude the other planes, not because I'm not interested in them, but because they didn't give me as much useful information. Now, what happens when I check the coronal plane and I don't find much of interest? Well, at that point, if somebody's talking about something going on with their back, with their ribs, with whatever might be of interest, I will add in the sagittal and transverse planes because I haven't found anything. So that's an example of I've purposely kind of cut some things out, cut some steps out, because implicitly I learned over time that the coronal plane was the most valuable to me. The transverse plane might be the most valuable to you. The sagittal plane might be the most valuable to you. But I purposely cut it out because I got the most information from the coronal plane. So that's an example of implicit learning. What I do when it doesn't show me what I'm looking for, or it doesn't show me anything, I add the other two planes in because I know that I haven't explored everything. So what I've done is I've purposely cut things out such that when it doesn't work, I'll add other things back in. So we've kind of meandered a little bit and spoken about the concepts of large movements showing small problems, macro identifies micro, having a clear-cut algorithm on purpose, and that over time, as you use that algorithm, you'll have explicit learning and implicit learning. You really don't have explicit learning unless you purposely try something. So purposely remove the sagittal plane from your assessment, purposely remove the coronal plane from your assessment, whatever it happens to be, and see what the results are. That's kind of the explicit portion. The implicit portion tends to be over time. You identify what's working, what's not working. You do it without knowing it, but it helps when you've done it on purpose. So we've talked about that. Now what I want to do is we're going to move over to a demonstration with the patient on the table, just to start to kind of highlight this a little bit more with visual opportunities to maybe bind this information a little bit better. So we're speaking about the concepts of assessment and the concepts of implicit learning and leaving things in, taking things out, macro identifies micro. So usually in a situation where I would start my assessment, I'd actually be seated behind the patient or standing behind the patient. And whatever I do, be it starting in a seated position or a standing position, when I retest, I do the same thing. So I don't sit down to start and stand at the end of the treatment when I'm reassessing. I do the same thing just for as much consistency as possible, understanding that as a human, I am highly fallible in my capacity to measure. And because I'm highly fallible in my capacity to measure, what I'm really looking for is, again, clear things. So we talked about the concept of emotion not crossing a threshold and not being important, or as important. So essentially, like I said, what I've done over time through implicit learning processes, I've removed the majority of the planes, or the two of the three cardinal planes, and I started off with just the coronal plane. So essentially what I would do is, again, I'd be on the other side of the patient, and I'd have my patient just bend to the left side, right? I just take a look and see what that's like, and then I have them bend to the right side, right? And in this situation, I'm not able to see, but that's my general pattern. As an example, should the patient bend well to the left and not as well to the right on a large scale, that immediately puts in my head that theoretically, and this may not be able to be proven as I stated, but the muscles on the left would be shorter, or they would like to shorten and not like to lengthen as much. They may actually feel fairly soft because a shorter muscle isn't always a hard muscle, as far as a tactile sense, but I would be more curious about these muscles. So if my patient happened to like to bend to the left more, all I would remember is left. I wouldn't think, L5, S1, I wouldn't think T10 to L3. I wouldn't be doing that unless it became very clear in the way that my patient moved in the coronal plane that there was something else going on. So often what will happen, well, not necessarily often, but you will see it where somebody is moving in the coronal plane and there's a clear deviation in the transverse plane. One side of them stays more rotated or more backwards. You can see it clearly. So that's one of the reasons through my implicit learning processes over time that I removed the transverse plane, is because when somebody bends to the side or somebody side bends, it becomes clear if there's a transverse deviation or there's something in that plane. If there was nothing when the patient bent side to side, if it was even in both directions, what I would then do is, as I've said before, I would add in the sagittal and transverse planes. I would add those in. So I would do that by having the patient bend forwards and backwards and then twist side to side. In this case, we're talking about this conceptually, but using some visuals for you. So again, if the patient happened to bend well to the left and not well to the right, all I would remember, I wouldn't remember the small things, I would just remember left or side bending left. Then I've already have some opportunities to triage and to set up what I'm going to do. So as far as the vertebral column is concerned, I want to lengthen the muscles on the left, and there's many ways to do that. After this point, so I've gotten my general assessment of the torso, of the thorax, of the vertebral column. I've got that generally in a very big sense. And like I said, I tend to use the coronal plane. I don't only use the coronal plane, but I will only add in the other steps should I not find what I'm looking for, or find anything. Not necessarily what I'm looking for, but not find anything. Shall we lay on your back? So at that point, then what I do is I will put the patient on their back, again, algorithmically, or in creating an algorithm. Some of these motions are ones that were shown to me, they made sense to me, so I continued to use them, and then in using them, I created or had the opportunity to make explicit choices that led to implicit learning, right? So explicit learning leading to implicit learning over time. So down at the feet. Now, in doing this and holding both legs and holding both feet, what I'm able to identify is which leg or which side of the lower body is more curious to me or has more motion dysfunction. So I would rotate the legs, and if I don't notice anything of interest, if there's nothing that really pops out as uneven one leg to the other or just generally restricted, I don't note it, I don't worry. I'll then pull the leg across. Sometimes I will pull it out, often, not exclusively, but as I pull that across, immediately this doesn't look like adduction that I'm used to or that I think is relatively free. So immediately in my head, I code left hip, right? The left abductors might be on the short side or might require to be considered. If I compare this, the right side seems more free. So again, what that does, ruling in, ruling out, I'm already more concerned with the left hip. That works just fine. Now I come through here, do a straight leg raise. That doesn't pop up as anything that is particularly concerning to me, so I don't code it, I don't remember it, because it's not something that crosses the threshold of being of concern with respect to motion dysfunction. Test that. Again, nothing of major concern. So immediately what I have, theoretically speaking, in my mind, left side bending, left hip. Those are the things that are of concern to me. And which plane, specifically in the coronal plane, and we're talking about restriction in adduction and freedom in abduction. Okay, so those are things that have already come into my mind. Again, understanding that there are things that I'm not doing in a small sense. I'm making those big movements to identify what subcomponents may be problematic. I come into the upper region. Now, I can do this both arms at the same time. I tend not to, partially because I'm able to remember side to side which one is of more concern. Also because I go through the coronal plane and generally through the sagittal plane, because this codes to me. So if something pops up, if I'm in the coronal plane, I'm more likely to think of the rotator cuff, I'm more likely to think of the lats. If I'm in the sagittal plane, often based on personal experience, again, that explicit learning to implicit learning, often it codes a little bit more of the pectoral mass for me. So then I come across to the other side, and I repeat the same process, just remembering left to right, and neither one of the shoulders or neither one of the arms really codes to me. It doesn't suggest to me that there's something crossing a certain motion threshold or a certain restriction, so I don't remember it. Again, left side of the back, left hip. Those are the things that I remember. Again, keeping in mind that I'm not going to go to the smaller joints. I'm not going to try to remember what the smaller joints are doing. It's just too much to think about. Or at least too much to remember in a functional way. I would then go and check the neck. And then should there be anything that doesn't make sense, should there be anything that essentially doesn't add up, I would have to investigate further. But right now, based on what theoretically or realistically that we've seen with this patient, I'm looking left side of the back, left hip. Those are my concerns. After I treat those in whatever way I should choose to treat them or interact with them, what I'll do is run the test again. I will see what happens to the patient, and then anything that's left over, again, we kind of narrow in, so we go from big to small. Again, just trying to demonstrate with a patient on the table as well as talking, and understanding that I can't necessarily retrieve all my thoughts in a way that I'm able to articulate, even in an organized fashion. What we're looking at is going from big to small, so macro identifies micro, concepts of implicit learning and explicit learning. So we're just talking about those and showing them to a degree, because if I was to try to remember exactly what the ankles were doing, exactly what the knees were doing, exactly what the hips were doing, exactly what the lumbar spine, each vertebral level in the lumbar spine was doing in the lumbar column, each group of ribs, that's a lot to remember and to then go back and make a choice on. So instead of having huge data sets, what I've done is I've come up with the concept, or not necessarily come up with the concept, but identified that remembering that many things makes it very hard to wield, hard to do anything with. So I remove a lot of that by saying, first, I check big things. If there's a problem with the big thing, it's going to point as to where the smaller subcomponent issue might be. So macro identifies micro. And over time, I've also purposely done testing only in one plane, testing in 2 planes, testing in 3 planes, and I've identified what works well, consistently, what works less consistently, and then because I identified that, I went to the coronal plane primarily with the vertebral column, and I understood that if I don't identify something there, then I've got to add in the other planes, recognizing that usually when I test the hips, I only test adduction. I don't necessarily test abduction all the time, but if the patient is complaining about something with the lower limb, and I don't find anything in adduction, I add in abduction. That's when I add it in. When there is something, as far as the patient's complaints are concerned, that is not adding up to what I'm identifying. So again, we just have an overview here, hopefully reinforcing or helping to understand some of the concepts that we've talked about before. Again, showing it one more time, adding in a few more explanations.